So next we'll see about the various types of carditis. Carditis is nothing but inflammation of the layers of the heart. So in heart we have pericardium, myocardium and endocardium. So each of these layers can undergo inflammation. So let's start with pericarditis. So pericarditis is going to be inflammation of the pericardium. It can be either acute or chronic. So in acute pericarditis, it will usually result in effusion. So pericardial effusion. Effusion is nothing but fluid accumulation in the pericardial cavity. So pericardial effusion can be of various types depending on the type of fluid which is getting accumulated. So we have serous pericarditis, fibrinous pericarditis, hemorrhagic pericarditis, purulent pericarditis and caseous pericarditis. So let's see examples for each of them. So in serous pericarditis, it is going to be a thin watery kind of fluid. Okay, the watery thin kind of fluid is seen in serous pericarditis, and the classical examples of this will be systemic lupus erythematosus and rheumatic fever. Other than that, we have fibrinous, serofibrinous kind of pericarditis. Usually, serous and fibrinous kind of pericarditis occur in a combination. That is why it is referred to as serofibrinous pericarditis. And the serofibrinous pericarditis is going to be the most common type of pericarditis. So, what is this fibrin? Because fibrinous kind of material, some thread kind of material will be seen along with the fluid in the pericardium. So, that is why it is called as a fibrinous pericardium. So, some immune complex kind of disease will result in this kind of fibrin formation, which will give this thread-like appearance. So, the classical examples of this will be rheumatic heart disease, SLE and Dressler's syndrome. So, in rheumatic heart disease, it has been given a specific name as bread and butter pericarditis. Now, it is nothing but just imagine two pieces of bread which has been spread with butter. Then you stick both of them together and then you again displace them. So how will it look like? It will look like some material is being sticking upon it, right? So that kind of an appearance is called is what we see in a fibrinous pericarditis. So that is because of the fibrin material, it is going to appear like that, uneven. So that is why rheumatic heart disease, it is going to be called as serofibrinous pericarditis or bread and butter pericarditis. Also, this kind of pericarditis is seen in Dressler syndrome. So Dressler syndrome is nothing but post-myocardial pericarditis, which is again a serofibrinous kind of pericarditis. So that is called as Dressler syndrome. Moving on to the next type of pericarditis, which is hemorrhagic pericarditis. So, as the name suggests, here blood is going to be accumulated in the pericardium. And the common causes of hemorrhagic pericarditis will be any kind of malignancy or even tuberculosis. So, what are the most common malignancies which can result in hemorrhagic pericarditis? Most commonly, it will be a lung cancer, which is resulting in this hemorrhagic pericarditis. Then the next type of pericarditis, which is purulent pericarditis. So, in purulent kind of pericarditis, there is going to be pus-like material along with neutrophils which are going to be present in the pericardial cavity. So, that will result most commonly due to some bacterial infections. And the next kind of pericarditis will be a caseous pericarditis. Caseous necrosis will be present in the pericardial cavity, and we all know caseous necrosis is always most commonly due to tuberculous condition. So tuberculosis can result in two kinds of pericarditis, which is hemorrhagic pericarditis, and other than that we also have caseous pericarditis for tuberculosis. Okay, next we'll see about the chronic pericarditis. So whenever we have any chronic condition, it is going to result in fibrosis. That much we all have understood now, right? So fibrosis is going to be there. So there is going to be pericardial fibrosis. So when pericardium is going to get fibrous, how will it look like? It is going to form a encasing sheet around the heart. So the heart will not be able to expand properly. So there is going to be diastolic dysfunction. So this pericardial fibrosis is called as chronic constrictive pericarditis because it is basically constricting the heart. Okay, and the most common cause of this constrictive pericarditis is going to be tuberculosis again. And since this fibrosis is going to form a sheet-like material around the heart, it is also given some other names like soldier's plaque, epicardial plaque, or milk spot. Okay. So next we'll say about the myocardial inflammation, which is myocarditis. The most common cause of myocarditis will be a viral infection usually. And remember, it is herpes infection which is more commoner than the Coxsackie infection. Okay, herpes is more common than Coxsackie viral infection. And if they specifically ask about what parasite is going to cause myocarditis, then you will answer it as Trichinella spiralis. Okay, this is very important. It can be, if you don't read the question, you might miss it or you might answer wrongly. Okay, next we'll see about the endocarditis. Endocarditis is inflammation of the endocardium. So basically the heart valves are going to be inflamed due to various conditions. So we'll be discussing 4 conditions under this. So starting with, it will be rheumatic heart disease, infective endocarditis, non-bacterial thrombotic endocarditis, and Libman-Sachs endocarditis. So these 4 conditions we'll be discussing under endocarditis. So endocarditis is going to form some vegetation or verrucae around the valves. So that is the classical feature of endocarditis. So let's see what kind of verrucae are formed in various diseases. Starting with rheumatic heart disease. So rheumatic heart disease are very important in medicine also. So here the classical age group which is being affected will be a 5 to 15-year-old kid, and he'll be presenting with some sore throat infection, and after a week or two the kid is going to develop some joint pain and then heart disease. So that will be the classical history given for a rheumatic heart disease. So what is the pathogenesis involved in rheumatic heart disease? Here it is going to be group A beta hemolytic streptococci, which is going to cause this throat infection, pharyngitis. So group A beta hemolytic streptococci, especially the strains which are 1, 3, 5, 6 and 18. So why are the strains important? I'll tell you in a while. So remember, strains 1, 3, 5, 6 and 18 of this group A beta hemolytic streptococci is going to cause pharyngitis. So antibodies will be produced against this streptococcal M proteins. So this streptococcal M proteins, against this the body is going to produce antibodies, and these antibodies which are produced are going to cross react with the host's own tissue. So it is going to result in a kind of hypersensitivity reaction here. So what will happen here? The host tissues, especially the heart and joints, so they'll be the ones which are affected because of this cross reactivity or molecular mimicry. So in heart, it is going to be the mitral valve which is going to be most commonly involved. So the patient will present with mitral stenosis or mitral regurgitation. Other than that, joint fleeting type of pain will be there. So when I mentioned about this, what was it important about this is, this streptococci, group A beta hemolytic streptococci, can also called a kidney condition called as post-streptococcal glomerulonephritis. We all must have known cola colored urine, right? So post-streptococcal glomerulonephritis can also be produced by the streptococci, but the strains there is different. The strains will be 12, 4 and 1. And remember one other thing, in PSGN, the this PSGN can present post pharyngitis and also post a streptococcal skin infection, which is impetigo. Okay, post impetigo or pharyngitis, it will be seen for PSGN and not for RHD. Remember that. So next we'll see about the phases of RHD. So in acute RHD, what are the features we see? The most important feature and image-based question also will be ash of bodies. So ash of bodies are nothing but a collection of fibrinoid necrosis along with an Anishkov kind of cells. So Anishkov cells are nothing but macrophages only. These macrophages are going to have a caterpillar kind of a chromatin. So this kind of a caterpillar kind of a chromatin will be seen in Anishkov cells. So in this picture, all these cells are Anishkov cells. So this collection of Anishkov cells along with fibrinoid necrosis in any of the layers of the heart is going to be called as ash of bodies. So remember, ash of bodies can be seen in any of the layers, but the most common layer which is going to be involved will be the myocardium. Then what about the vegetations which we see in acute RHD? So the vegetations or the verrucae here we see will be very small and warty, and it will be present along the lines of closure of the valves. So suppose this is the valve. Here this is the mitral valve. So the vegetations are going to be present along the lines of closures of the valve. So this is where the vegetations will be present. So this location of the vegetation and the type of vegetation is very important for distribution between the types of endocarditis. Then we'll see what a chronic RHD. In chronic RHD, we don't see any of these ash of bodies or vegetations. Remember, ash of bodies and vegetations are not a feature of chronic RHD. They are features of acute RHD. So in chronic RHD, what will you see? Like I mentioned, any kind of chronic disease will result in fibrosis. So because of this vegetations, the valves will be damaged and they'll undergo fibrosis. So when the valves undergo fibrosis, they will become like this, like they will be stenosed. Because of fibrosis, they are going to be stenosed. So it will result in something called as a fish mouth or a buttonhole stenosis. Doesn't it look like that, like a buttonhole? So this is the valves opening which has literally stenosed. So this kind of fish mouth or buttonhole stenosis is a feature of chronic RHD. And because of this stenosis, what will happen? The blood is not able to pass through the valve. So the blood flow will be regurgitated, and that regurgitated blood flow is going to go and hit the left atrium, because mitral valve is the most common valve. So left atrium, this blood flow is going to go and hit, and the place where it hit it's going to form a plaque. So this kind of plaque, which is present on the posterior wall of the left atrium, is going to be called as the McCallum plaques, which is a feature of chronic RHD again. So this McCallum plaques is a result of actually the buttonhole stenosis. So how do you diagnose RHD? We have a specific criteria called as Jones criteria. So Jones criteria, if you expand, we'll have to use 2 major criteria, or there should be 1 major plus 2 minor criteria to call it as rheumatic heart disease. So what are the major criteria? So for that we use the term Jones criteria itself. So J for joints, JO for joints, and then N for it will be nodules, and then E for erythema marginatum, and then S for Sydenham's chorea, and criteria is for carditis. Carditis is criteria. Okay, so remember it like this. So Jones criteria, you can apply it for the major criteria as well. So in joints, what is the feature? It is going to be migratory polyarthritis. Migratory in the sense it is going to involve large joints basically, so knee, elbow kind of joints. So from one joint it is going to move on to the next joint, and when it move on, it doesn't leave any residual deformity in the joint which was involved. So it is a non-erosive kind of a polyarthritis which leaves no residual deformity, and the joint pain will be the most common and the earliest symptom with which the child is going to present. So fleeting type of joint pain is a classical feature of RHD. Other than that, the patient can also have subcutaneous nodules. So these nodules are again present near the joints, especially near the elbow, and these are again painless kind of joint nodules. Then we have erythema marginatum. So it is a particular rash in which you see a peripheral darkened rim and a central pallor. So this kind of image will be seen in RHD, and here it can involve mainly the trunk and the arms, sparing the face. Then it can also present with Sydenham's chorea. So chorea, we all know it is a involuntary movement. So that will be a late manifestation only, which we see in RHD. Then pancarditis. So all layers of the heart can be involved in RHD. Very, very important. All layers of the heart can be involved. Same for ash of bodies also, right? All layers, we can see this ash of bodies, but the most common finding will be the place where we see this ash of bodies will be the myocardium. Apart from that, in pericarditis, already we had seen bread and butter pericarditis, serofibrinous kind of pericarditis in RHD, right? So remember that as well. Then what are the minor criteria? Here we have fever, polyarthralgia, elevated ESR, and elevated PR interval. Okay, on ECG we can see an increased PR interval as well. So for a supportive evidence, that is to tell it was because of the streptococcal infection only this RHD has happened, we need to prove the streptococcal infection. So for that we need to do either a rapid antigen test for streptococcal infection or ASO antibody titers. So anti-streptococcal antibodies. So ASO titer antibodies we can find, or we can do a throat swab culture sensitivity for the streptococcus. So using this revised Jones criteria, we can diagnose RHD. So RHD, remember about the stains, post-pharyngitis, the age group. And about age group, I'll mention one other thing. Not all kids develop RHD, right? Only 3% of the kids are known to develop RHD. And some kind of other factors also come into play. Okay. And the main pathogenesis of RHD is going to be molecular mimicry. So next we'll see about infective endocarditis. So as the name suggests, the endocarditis is going to result from some infection, and this infection is going to result in the formation of vegetations which are quite friable, and since these are friable, they'll be detached and then they can embolize to various parts of the body and deposit there, and again there also they can cause abscesses. and this will damage the valve quite hardly. Okay, so we have various forms of infective endocarditis, which is acute and subacute infective endocarditis. So acute endocarditis is the one in which the infection will be on a normal valve. So a normal valve, the infective organism is going to cause damage. So the organism which is most commonly associated with acute infective endocarditis will be Staphylococcus aureus. While in subacute infective endocarditis, there the organism is going to affect some damaged valves. Already the valve is damaged by some other disease like valvular disease. So on that damaged valve, it is going to cause infection. And the most common organism associated with subacute infective endocarditis will be Streptococcus viridans. Suppose the patient is having a prosthetic valve already. So on that, the infection which is most commonly associated will be a Staphylococcus epidermidis, which is a coagulase negative organism. So Staphylococcus epidermidis. Then in IV drug abuses, it is usually through the veins they inject, right? So through the right heart only it is going to enter. So the right heart is going to be affected more than the left heart in IV drug abuses. That is, the tricuspid valve will be affected more. And here, if in the tricuspid valve, the infection will be more commonly due to Staph aureus. While if it is an aortic or a mitral valve, the organism is going to be enterococcal infection in IV drug abusers. So these can be asked as direct MCQ questions. So for that, you need to know the organisms involved in each of this in infective endocarditis. So the classical feature about the endocarditis I already mentioned, it is going to be the location of the verrucae. So in infective endocarditis, I already told it is going to be large and friable kind of vegetation, and this is the only vegetation which is going to be non-sterile because it is caused by infection, right? So it is the only vegetation which is non-sterile, and since it's friable, it is going to break and embolize. There it is going to result in mycotic aneurysms and some ring abscess or any abscesses wherever it gets deposited. Okay, then the location of this verrucae in the valve itself will be present on the upper surface of the cusps. So there we drew, it was on the lines of closure, right? Here, if it is like this, the verrucae will be present on the upper surface, okay, on the upper surface of the valves. So the clinical features can be either related to the abscesses, wherever it's going and depositing, there it can cause infection, right? So it can be related to the kind of place it is getting deposited, or even it can be due to some immunological or a vascular phenomena. So let's see about the vascular and immunological phenomena because they can be asked as picture-based questions as well. So the first image, if you see, it is having this flame-shaped kind of hemorrhages. So these flame-shaped kind of hemorrhages, no? So these are seen on the retina. So these flame-shaped retinal hemorrhages are called as Roth's spots. Roth's spots and Osler nodes are going to be immunological phenomena associated with infective endocarditis. So Osler's nodes are nothing but in the pulp of the fingers, you see this painful kind of nodes. So these are nothing but Osler's nodes. So remember, Osler is for pain. So pain usually we shout as ouch, right? So O for O. So ouch we shout. So it is going to be painful. So and then we have some vascular phenomena also, that is they are going to be smaller hemorrhages at various places. So in the nail bed, it is going to be called as splinter hemorrhages. So can you appreciate this? So these are nothing but small hemorrhagic areas on the nail only, and these are called as splinter hemorrhages. And same kind of hemorrhages can be seen on the palms and the soles as well, and there it is going to be called as Janeway lesion, and these Janeway lesions are going to be painless. Okay, that is why I asked you to remember Osler's nodes are painful while Janeway lesions are painless. So how do you diagnose infective endocarditis? We use the modified Duke's criteria. So the criteria has slightly changed from before. So I'll specify that alone. So in order to prove the infection, we need to do blood cultures, and the blood culture should be usually 2 blood cultures taken 12 hours apart. You'll have to find the organism which is typical for causing this infective endocarditis. So the organisms which are to be typical were the Staph aureus, Streptococcus viridans and all these things, right? So these organisms has to be proved by blood culture, 2 samples 12 hours apart. But if the organism which is going to be causative is Coxiella burnetii is the organism responsible for causing Q fever, right? So Coxiella burnetii is the cause for infective endocarditis, then we need only a single positive blood culture, no need of 2 blood samples. So that thing you need to remember. Other than that, we have major and minor criteria in Duke's criteria as well, based upon the vascular immunological phenomena and evidence of this heart echocardiac features also. So I'm not going into detail about that. Next, we'll see about the other causes of infective endocarditis, which is non-bacterial thrombotic endocarditis and Liebman-Sachs endocarditis. So the first one, non-bacterial thrombotic endocarditis, as the name suggests, it is going to be non-bacterial. So it is a sterile kind of a endocarditis. Then thrombotic, meaning it is going to have formation of thrombus. So when will thrombus form? There should be some procoagulant stimulus. So it will be seen in any hypercoagulable states like acute promyelocytic leukemia. So APML, one example. Other than that, we have lung and pancreatic cancers wherein when they produce mucin. So the mucin is known to be a procoagulant. Okay, so mucin producing carcinomas, adenocarcinomas, they can also result in NBTE. And this is also called as Rheumatic endocarditis. And the classical location of this non-bacterial thrombotic endocarditis will be again along the lines of closure of the valves only, like that of an RHD. But here, since the name suggests thrombus, so this thrombus is also going to be fragile like infective endocarditis, and it can also embolize. So this is a very important feature. So how will you differentiate it from infective endocarditis? Here it is going to be sterile, okay, and present along the lines of closure of the valves. Then Liebman-Sachs endocarditis. Liebman-Sachs endocarditis, if you put it in short form, it is LSE, right? It is going to be seen in SLE. So if you jumble up these words, it will look like SLE. So Liebman-Sachs endocarditis is present in SLE. And here the vegetations are going to be present on both the upper and lower surface of the cusps. Okay. So if this was the valve, we are going to see the vegetation present on both this surface and both on the lower surface, but more on the lower surface. That is very important. So how do you remember this? So LSE itself, Liebman-Sachs endocarditis itself has LSE, right? So LS is for lower surface. So remember it like that. Both surface you can have vegetations in Liebman-Sachs, but more common on the lower surface. So now we had seen about all forms of carditis, pericarditis, myocarditis, then endocarditis. And endocarditis we saw about RHD, infective endocarditis, NBTE and Liebman-Sachs endocarditis.